You're listening to The Q Switch with your host, Spence.
Welcome, one and all to the Q Switch Conversations podcast. I'm your host, Spence, and the mission of this show is to tackle relevant subjects currently impacting ophthalmology, where we attract the innovators, thought leaders, and forward thinkers in the field of ophthalmology today and into the future. My guest today is none other than Dr. Alan Schlussel, an optometric physician with over 30 years of private practice excellence across Midtown Manhattan and West Orange, New Jersey. He's been named one of Newsweek's top 150 optometrists in America, is a fellow of the American Academy of Optometry, and has built one of the region's premier dry eye centers of excellence, long before dry eye became the modern epidemic we recognize today. Dr. Schlussel is a clinician's clinician, deeply trained, deeply experienced, and deeply committed to patient-centered care. He's treated thousands of cases of dry eye and meibomian gland dysfunction, MGD, co-managed a huge volume of refractive and medical cases, and continues to lecture, teach, and lead conversations on the future of eye care. As a New Yorker, I would be remiss if I didn't mention at the top that outside of the exam room, he's a diehard Mets, Knicks, and Rangers fan, and long-suffering Jets loyalist, and a rock concert regular. For all of our Gotham City folks out there, the perfect guest to have on the show today. So get ready, people, because today we're diving into the evolution of optometry, the dry eye revolution, new pharmacological breakthroughs, device-based game changers, the rise of AI, and how the OD-MD partnership continues to transform patient outcomes. Dr. Schlussel, thanks for making time for this Q Switch. Welcome to the show.
Thank you for having me. My pleasure.
So, Dr. Schlussel, you've been practicing for over 3 decades in 2 incredibly dynamic communities. Let's start from the beginning. What first inspired you to pursue optometry, and how has the profession changed since those early years?
My biggest person that I looked up to was my dad. He was an optometrist practicing in the 50s, 60s, and the 70s. He was my role model. Went into optometry just because I wanted to be in the medical profession, and I liked dealing with eye care. I had always had glasses, contacts growing up, and I was just passionate about it.
Well, I'll tell you this. One of the things that as I've been, doing the show and being out in the marketplace and working with optometrists, it is the most common thing to have second-generation optometry practices where father-son, father-daughter, and so on. Is that, why do you think that is, just out of curiosity?
I guess you see your dad or mom having a good life with it and enjoying what they do, and you just share the passion.
There's just so many.
The field has changed tremendously. Is the second part of your question, what has changed about optometry?
Yeah.
When I entered optometry in the 80s, optometry really didn't have much of a footprint in the treatment of and management of ocular disease or co-managing. It was basically a refractive profession. And with the gains of our state boards over the years, we've gained the use of topical and oral medications to treat dry eye and treat other ocular diseases like glaucoma.
So of all the things that have changed over the years, what's the one thing that made the biggest and most impactful shift, where there's technology, scope of practice, as I think you just mentioned, with different laws being passed and everything, or just patient expectations? What's created the biggest impact on your day-to-day practice?
I'd say the change in scope of practice. New Jersey gained the legislation for topical and oral medications in the 90s. And I think the perception of the patients that their eye doctor is and would be their optometrist, because early in the days of the 70s and 80s, patients would know the difference. I went to my optometrist to get glasses. I went to my ophthalmologist to get a real thorough eye exam. And now it's one and the same. I am their eye doctor. They don't really look elsewhere for eye care unless it's for a specialty kind of cases like retinal problems, corneal problems, or cataract surgery.
And thankfully so, because I think the demand for eye care services far outweighs the ability for just the ophthalmologist, the MD community to meet. So to be able to shoulder some of that burden, I think allows patients to be treated more often and with a higher degree of care.
Absolutely, especially in not necessarily my states, but in the rural states where a patient can go to a local doctor and not have to travel to a big city. And also, I think we've gained acceptance from our colleagues in ophthalmology who treat us as equals, and they don't necessarily want to do the primary care. Talents are much best served in the operating room and dealing with operating in more serious cases like glaucoma, cataract surgery, and they work alongside optometrists in many practices.
Of course. Something patients always mention about you is your warmth and personal experience you create in the exam room. What's the philosophy behind your approach to care, especially in fast-paced places like Manhattan?
I think I've stayed to my goals is to be friendly and to be thorough. And I haven't really looked in the back of my mind like I should be seeing 50 patients a day. I'm comfortable seeing 25 a day and have made a good living doing that. So I think just keeping to my goals and keeping to the nature of how I want to practice. I've been working for myself, so I'm not working for somebody else. And I've been able to do and run the practice the way I want.
Well, I think that more doctors should feel the way you do, like, because again, with the different changes in the industry and in the field, with private equity groups, larger hospital systems taking over smaller practices, and their expectations and pressures that sometimes come from the outside, and change the way a doctor and physician and clinician administers care, and be able to have the opportunity and be blessed to have your own practice where you practice the way you want at the pace that you want and provide the level of care that you think is best for your patients, I think is amazing.
Yeah, it's definitely. I mean, I've been happy to and feel lucky to be able to do that. And the associates that I work with and partner like that part, the feel of the practice that, their patients are coming to see them. They're not coming to see, corporate name on the window.
So you've built a dry eye center of excellence, and you were talking about dry eye long before it became the hot topic it is today. What initially sparked your focus on dry eye disease?
I think I just felt it was in the wheelhouse of my education, my knowledge. I'm passionate about so many things in my life, and I just became passionate about the needs of patients that come in with the symptoms of MGD and dry eye. And I felt that it was something that I was interested in, and I was able to buy the equipment and the resources in my practice to be able to, specialize in that area. And I was able, I think the help of my website, we have a separate website that markets both practices for dry eye. It's a separate from our regular website. So with the SEO that my website company provides, it's gotten my reach way outside my few towns that I practice in New Jersey and within the Midtown Manhattan. Gets me probably all over the globe. I have people that, go on our site and then have questions about other parts of the Europe and Canada, but many of them don't visit me, but maybe gives them the interest to go see a local practitioner.
So you said you started practicing in the 80s and 90s. So back then, treatment options were limited, maybe an artificial tear and a pat on the back. What's been the biggest mind shift or mindset shift in how we understand dry eye today?
I think the advent of new medications has helped. I mean, Restasis was the first one that came out probably 25 years ago, and that was the mainstay. And punctal plugs were the other thing that was used and still is used. But I think once we started to see some interest on treating the actual cause of the condition, as in LipiFlow came out also about 15 years ago, LipiFlow changed the game plan because now you have something besides medications to help the patient's symptoms. And now over the last, I guess, 7 years, 8 years, we have IPO and radiofrequency that helps us in that area.
I think I have a question on that as well, and a little bit farther along here. But there are some exciting pharmacological advances. Can you walk us through what makes newcomers like Triptyr, Vivi, I think it is, and Zidemvi, I'm sure if I'm pronouncing those correctly, so meaningful in clinical practice?
Well, I think the latest one that's come out a few months ago is Triptyr. Kind of uses the pathway of nerve tissue that goes through the nose and into the eyes, and it seems to generate natural tears. So it kind of triggers the inflammation and stimulates the tear production by the seventh nerve, that the pathway going through the eye. And it really works quite well. Patients have some stinging and burning when it goes in, but it's been very effective. And the FDA trials showed it was very effective in producing not only just the aqueous, but also helps with the meibomian gland function in terms of the oil in the tears. So that's been, I think, one of the latest things that we've used. Vivi is another one that was more of another medication that added a type of water-free solution that added to the actual cyclosporin, plus the cyclosporin content was 1% versus Restasis, which is 0.05. So it gives us a more potent medication that also adds to the similarities to Mibo, that porofluctane that goes in the vehicle, and it helps actually make the eye more wettable and reduces the stinging that comes alongside cyclosporin by itself.
Oh, wow. Okay. All right. That's nice to have. I mean, I know that compliance is an issue. So anytime something stings, you're going to get a much less compliant patient. In the office, they'll do it. But when they're at
Exactly.
home, or at the office, chances are if it's going to sting, they're not going to be as compliant as you'd want or expect them to be to really maintain their therapy and improve. Now, you mentioned MGD is now recognized as the leading cause of dry eye. From tear care to IPL, you mentioned RF. What new device-based therapies have truly moved the needle for your patients?
Well, definitely LipiFlow was the game changer, years ago, but it really does it takes the oils and squeezes the oils and heats up the glands at the site of where the glands are located on the inside of the lid. So that was a game changer back 15 years ago. But now we've taken it to a new level by addressing the cause of the symptoms, which is the inflammation from telangiectatic vessels along the eyelid margin or along the face, and it kind of knocks out a lot of the potency of those vessels to bring in inflammatory markers into the eye. Plus, RF has allowed us to get more deeper heating along the lid margins to then express the glands. Much more effective than topical hot compresses because they don't get as deep into the skin of the eyelid.
Now, these device-based therapies, are these type of therapies the kind of thing that are patient pay technologies, or what makes the economics work for the practice as well as the patient?
Well, it certainly works more effectively for the practice because the practice is not accepting assignment. It's not a covered procedure on most, if not all, medical plans. So the doctor is putting out a fee to the patient. The patient's paying out of pocket and allows you to, pay off the cost of your equipment quicker and a lot more profit for the practice. So it
Of
gives
course.
the clinician who owns the equipment the impetus to treat it. Plus, a lot of patients now coming in are concerned about all this medication they're taking. It's a big
Mhm.
thing that's talked about in other areas of medicine. I'm taking all this medication. Is that good for me in the long run? And I think there are patients that are welcome to the additions of, getting to the root cause of dry eye, root cause of meibomian gland dysfunction by using vehicles that can reduce the inflammation and allow the meibomian glands to breathe better and get a natural oil flow out of their eye.
So we're also seeing a rise in regenerative approaches, autologous serums, PRP, and biologics. Where do these fit in, especially for severe or refractive cases?
I think they fit in nicely. I mean, there are many patients that come in and have neuropathic concerns where the patient's coming in with a lot of symptoms. You give them a speed questionnaire and they're checking off every box. But when you look at their eye, they really don't have any noticeable signs on the eye. So it's more of neuropathic pain. And I think that the immunobiologics have been very effective in serum tears and giving that patient seems to react pretty well to that. And there are cases where a patient doesn't do well because there's a disconnect between what the brain feels or reads versus what the eye is triggering. So some of those patients will do better with oral medications like gabapentin and things like that.
So you emphasize customized care. In your practice, what does true personalization look like when managing dry eye?
Well, you're looking at the patient, you're doing some testing, you're going to do meibography, you look at their tear quality, you're looking at their aqueous content, the tear breakup time, and those things are showing you that maybe there's more aqueous problem that you may want to treat differently with plugs or possibly vehicles that can improve the aqueous. But, as we discussed before, 90% of the cases are really mixed or MGD by itself. And those patients you have to address the root cause. Going back to the root cause is inflammation. How do you control inflammation? We know that steroids, the soft steroids do well with that, but that's not a long-term cure. It's more of a short-term, let's get rid of the inflammation to make the eye feel better. But then you want to do something that'll keep that inflammation down. And that's where IPL comes in.
So have you have any experience with Procera, the amniotic membrane with addressing dry eye at all?
I have. In a limited amount, my partner in New Jersey has had a lot more experience. She does quite a few cases. And you do see some improvement in patients that have really a lot of SPK or a lot of symptoms, especially the neuropathic pain and neurotropic pain. They do well, but it's not something that can be done that frequently to the point where it's not as good a long-term cure, I think, as the biologics would be, serum tears. But it's a good approach. And for the practice, it is a good reimbursement. So that's not something the patient pays out of pocket. Most, if not all, insurance companies are covering the cost of that.
Well, good. I think what you're saying is that in terms of personalized care, you have an expertise in a very wide range of therapies. So whatever formula or combination of treatments and therapy that this patient and their data tells you is what you're going to prescribe them. Because there is no one size fits all. I think that, and you can correct me if I'm wrong here, that dry eye disease and other ocular surface diseases affect each person individually, and you're able to, again, craft their own prescription, if you will, for care and improvement.
Absolutely. I mean, especially the patients that are really coming in with, lots of symptoms, pain as being one of them. Those patients, you can't put cyclosporin in their eye. You can't put the generic cyclosporins because it's going to burn like heck when there's a lot of SPK on the cornea. Plus, the patient's really not going to get better from it. So you really have to go with a different way to treat them.
So now let's get into the tech. AI isn't replacing clinicians, but it is definitely changing how clinicians work. Where have you seen AI already making a real difference in eye care?
It hasn't, I think, made a real difference yet, but I think it's soon to come. I would love to see, and I think it's in the works, an automated way for my biography to be done one year after year and have AI to look at previous pictures or my biographies on patients and be able to tell you how much has improved, how much has stayed the same, how much has gotten worse, and be able to really measure the size and the thickness of the glands and what areas have been affected. Right now, we don't have a lot of technology to show us that. So it would be great for AI to take that time because it is very tedious to put, 3 or 4 of my biographies on a screen and show a patient. And kind of from a patient's perspective and even a clinician's, they all look the same. You're really not making accurate measurements on the size, thickness. And I think AI could do a great job with that and doing that work for the clinician.
What about predicting who will respond to which therapy? IPL, lipoflow, cercratagogues. How close are we to that being a standard feature of dry eye care?
I think we're close. I mean, I think there's a couple of companies, going to the patient side and the doctor side to have some type of portal where you ask them the questions and the patient fills out surveys and it can then collect the information time after time, month after month to see if the symptoms and then try to get into the data of the practitioner to look at my biography to your breakup time and put that all in one formula to kind of tell the client and the patient what's happening and is the patient getting better and why.
You've co-managed countless LASIK and medical cases over the years. How has the optometrist-ophthalmologist partnership evolved, and what does great co-management look like today?
Well, I think it's evolved quite a bit. I mean, ophthalmologists are routinely co-manage their cataracts and LASIK and refractive surgery patients to the point where we report back to each other. We send them a referral. We say the patient has this interest, and then they'll go along with the surgery and keep us updated with follow-up letters and reports. And we are responsible to take care of the patient after the first few weeks of post-op care. So I think it's evolved a lot, and I think it's great for the patient. Patients prefer to go back to their quote-unquote eye doctor. The surgeon is not something they have come from. They came from our practice, and they like to go back to familiar faces, and it works very well.
I agree. And once again, as I said earlier, I think the volume of cataract patients, glaucoma patients, the volume and demand is too high for the community of ophthalmologists, as good as they are, to handle all that without impacting the pace with which patients get treated and the degree of care I think that they deserve and expect. And I think that having the expertise and training of optometrists to be able to carry that load and be able to extend those services and really narrow the focus of ophthalmologists to the surgery is a good thing, especially in areas where there's high populations like in New York and other places around the country. So I think that the evolution and development of that relationship has certainly been more positive now than it was in the past because of some of those things that happen in the marketplace with patients.
No, I agree 100%. And I think the thing is that ophthalmologists, many of them work alongside optometrists within their own practice, and they see the knowledge and the talents they have and the ability to communicate with the patient in having maybe more time with the patient versus the surgeon who's going back and forth from the operating room and then seeing follow-ups.
So you've again, long before it was, in fashion or popular, you really did focus on dry eye. And I think with different things impacting the field, AI and other technologies, as well as co-management, I'm seeing more and more specialization, not just in dry eye, but in specialty contact lenses and things like that, that really have almost on its own can naturally create an environment where optometrists, once they finish their education, they specialize in something, whether it's an official fellowship, if you will, or some type of specialized training for a period of time. Do you see that continuing to be the case? And what areas do you think are important for optometrists as they gain specialization to go into?
Yeah, I think they They do have many fellowships. I think back in my day, very few of my colleagues and graduating colleagues really went into a specialization. The big thing from my area of the country in my school was pediatric vision training. But now there's, multiple follow-ups in terms of specialty contact lenses, dry eye, again, more in pediatrics and post-surgical cases.
So for those young ODs entering the field or seasoned clinicians trying to stay current, what advice would you give them to prepare for success in, say, the next decade or in optometry?
I think stay up on their knowledge. Try to increase their knowledge. I mean, school, 4 years of optometry and 1 to 2 years of fellowship gives you limited experience in dealing in a practice, and especially if you're going to be an practice owner, you have to develop some skills on how to keep the practice running, keep it grow into areas, try to communicate with colleagues in your area that might not offer the same specialty care and try to earn their business in terms of referrals. Trying to be up on all the areas of your practice can really help the practice grow.
Well, I think that that's really great advice for no other reason that optometry, eye care in general is changing at a pretty rapid pace with technologies and therapies that are coming out. And you never know what the next best therapy or device may be to address a patient population you may have a large amount of. And so always be on the hunt, be on the lookout, and be aware of what's going on in the marketplace in terms of what's available to you is great advice because, again, something from a year or two ago may not be as effective as something that was recently come out in the marketplace. So again, always keep, as they say in football, keep your head on a swivel.
Yeah, I mean, I think even in our world, we have social media in terms of Facebook and Instagram, but now you have those specific areas of optometry, where there's social media and Facebook groups that you can discuss this among other colleagues in your field and in different areas of the country where you can say, how do you guys do it? How do you price this procedure? What is your experience with this medication? You really can start to learn more than you could back in the day. I mean, we didn't have that capability in the 80s.
So one of the things that I find with a patient who sees their optometrist is that something like dry eye is something that they have to, much like glaucoma, the patient has to participate in their own care to get the desired result. And it's a partnership. And so before we wrap, what do you wish patients better understood about their own role in dry eye management and ocular health overall?
Well, I wish they kind of would understand that the eye is not dissimilar from their teeth. When I use this analogy all the time with my patients, I think patients are used to being told by their dentist, brush every day, floss every day, because you can eventually, if you don't, have cavities, gum disease, or teeth loss. But now we're trying to give that analogous, take care of your eyes, take care of coming for routine exams. If you have indications of dry eye, which in my practice, I bring it up to probably 75% of my patients. I give it a handout. It goes over, things they can be doing at home, looking away from the screen, taking omega-3 vitamins, but take it seriously, not to be obsessed with it, but try to take it serious. Like try to do the hot compresses daily. Try to wash your eyelids off. Females wearing makeup and men wearing makeup for, actors, actresses, is to try to be really careful about cleaning the lid margins, because if you don't, those glands will clog up and all the stick to screens is going to make it worse, and they're going to be more susceptible to the typical hordeola, preseptal cellulitis, and the symptoms of dry eye.
Well said. Well said. Well, Dr. Schlussel, this has been an outstanding conversation full of insight, experience, and the kind of clarity that only comes from decades of hands-on care and deep passion for the profession. Your perspective on the evolution of optometry, the breakthroughs in dry eye, and the growing role of AI gives all of us, clinicians and patients alike, a clearer view of where eye care is headed. Thank you for your leadership and teaching and your commitment to elevating patient care. If our audience would like to learn more or keep this conversation going with you, what is the best way to reach you and get in touch with you?
I think my email is very good to get in touch with me, dryeyecare@gmail.com.
Awesome. As always, we'd like to thank Riverside FM and Passionate Media for making this show happen, and of course, Meridian Medical for making it all possible. So the Q Switch Conversations podcast is my way of giving back to an eye care industry and community that's shaped my career, my perspective, and my passion for what we do. This platform is built for you and designed for you, the clinicians, the innovators, and change makers that redefine what's possible in our field. So if you've got a fresh perspective, a unique experience, know someone doing great things in eye care, I'd love to have you on the show. Just hit me up on my LinkedIn or drop me a note at d.spence@meridian.ch. That's a wrap for this episode of the Q Switch Conversations podcast. Until next time, this is Spence, and I'm out.
You're listening to The Q Switch with your host, Spence.